summary for topic 22, purulent disease of serous cavity, and combined with topic 23, surgical sepsis. So our patient's name is Wong Yong Kyong, the age is 21 years old, and the sex is male. The address is in Pavlova Street. The professional is student, studying in Kerr State Medical University. Nationality is Malaysian, and the marital status is single. The date of administration is 26th of December 2023. Starting off subjective examination, the complaints of patients is having pain of the abdominal region. The onset is the pain started 2 days ago, and the characteristics of the pain is sharp, is intense, and the localization is at the right iliac region. And provoking factors is physical activities such as walking, running. Relative factors is lying on the affected side, which is lying on the right side. And the urination disorder is oliguria. The patient is having difficulties in urination. The additional complaints is headache, nausea, vomiting, malaise, and fever up to 38.9 degrees Celsius. The vomit is watery vomitous. The patient is also having feel of thirsty, lost weight, and also loss of appetite. The health history of present illness is the patient started having pain 2 days ago, which is 24th of September 2023, and the pain started from constant to intensive sharp pain, and the localizations of the pain is also changed from initially at the epigastric region and started shifting pain from epigastric region to the right iliac region. The intensity of pain also increased from the first day, which is 24th. The pain is 1 out of 10. The second day is 4 out of 10. And finally, the third day is 7 out of 10, and the patient comes to the doctor. And the patient has fever from the second day, 38.1 degrees Celsius in the morning, and unfortunately, he does not measure his body temperature at night until the third day, which is today. The body temperature rises until 38.9 degrees Celsius in the morning. And patients vomited 3 times in the second day, started from yellowish color with food particles, accompanied with food particles, until now the vomit changed to watery vomitous. The amount of urine output is also decreased, in weight loss from 5 kg, from initially 65 kilograms to now 60 grams due to the fluid loss and loss of appetite. So now we are talking about the past health history. The family does not have a history of chronic diseases, no GIT diseases. Patient does not have a stroke, does not experience myocardial infarction, no past operation, no history of trauma on the abdomen. There's no allergic to medication, no allergic to local anesthesia, no allergic to any anesthesia, no tuberculosis, no diabetes mellitus, no HIV, no hepatitis, no smoking, no alcohol, no drug abuse, no medical history, and no history of blood transfusion. But the patient has infected COVID-19 before and is already vaccinated with 3 doses. So my conclusion for the subjective examination is the patient is suspected to have acute abdomen peritonitis, and the causes is not caused by the operation in the abdomen because the patient has no history of operation of abdomen, and the elevations of temperature may indicate infection. As well as the sepsis, there's one evidence of sepsis which indicate the patient might have sepsis, which is the elevations of body temperature more than 38 degrees Celsius. Now we are talking about objective examination, starting from general inspection. General condition of patient is unsatisfactory. Conformity of age is older than the usual age. Consciousness is 14 points according to Glasgow Coma. The posture is false posture, the hand supporting the affected side, which is the right iliac region. The face is pen face. Constitution is asthenic, weight is 60 kg, height is 172 cm, and the BMI is 20. And the nutrition is polynutrish. Skin and mucous membrane, they are dry, they are pale skin, presence of cyanosis, absence of pigmentation, depigmentation, absence of surgical scar, they are dry armpits, dry tongue, skin sugar is decreased. Other than that, everything is normal. Nails, they are normal. Hair, they are normal. Subcutaneous tissue, lymphatic tissue, they are normal. There is no pathological. And for the muscular system, there's decrease in muscle tension and decrease in muscle strength. Bones and joints, they are pain while moving. Vertebral column, they are normal. Head, nose, eyes, lips, they are normal, while the cyanosis of lips is observed. The neck is cylindrical in form, there's no enlargement. Everything is normal. and body temperature is 38.9 degrees Celsius on the day of examination. So my conclusion for objective examination, the patient is having acute abdomen caused by infection. There's signs of intoxication, which is elevations of body temperature, and dehydration accompanied because the patient has dry skin, dry mucous membrane, dry tongue, dry armpit, skin turgor is decreased, and there's cyanosis of lips observed. For the sepsis, there's one evidence show that patient might suffer from sepsis, which is the elevations of body temperature. For the respiratory system, the form of chest is normostenic, there's no deformities of chest, while the respiratory rate is 30 breaths per minute, which indicate tachypnea, accompanied with participations of nasal wing. Muscle retraction is seen during respiration. Uniform expansions of chest, there's absence of lesion, absence of wound, absence of scars. While the palpation, surface palpations, there's no pain, there's no tenderness. Vocal fremitus is increased. Elasticity of the chest is not changed. Position of the trachea is in the middle. Percussion, comparative percussion that show down sound in the fourth rib of the right side. On the fourth rib of right side, topographical percussion shows that displacements of lower border of the right lungs upward. While auscultation, there's normal bronchial breathing sound, while vesicular sounds is weakening on the lower right lung. There's no rills heard, there's no crackles, there's no crepitation. For the conclusion, the respiratory system is compromised with increase of respiratory rate, muscle retraction during respiration. Increasing of vocal fremitus might indicates there's consolidations of the lungs. During percussion, the down sound is also shown and at the level of fourth rib in the right side, and displacements of the lower border of the right lung upwards, and weakening of vesicular breathing on the lower right, where it indicates that there's a presence of fluid in the pleural cavity. Further investigations of plain chest X-ray and ultrasound is needed to make sure. While sepsis is proven that the patient is suffering sepsis, as there are two evidence. The clinical situations of patient is matching which the elevations of body temperature up to 38 degrees Celsius and respiratory rate more than 20 breaths per minute. The investigations of severe sepsis is needed due to the compromisations of the respiratory system. Now we are talking about cardiovascular system. During inspection, there's absence of cardiac humpback, apex beat is present, absence of cardiac beat, absence of abnormal aorta pulmonary pulsations, negative jugular venous pulse, positive Quincke sign, absence of epigastric pulsation. For the palpation, apex beat is palpable, is in the fifth intercostal space, 1.5 cm medially from the left mid-clavicular line, and the heart rate is 120, which indicate tachycardia. The pulse is regular but weak. There's absence of systolic and pre-systolic shows. Capillary refill time is increased. Blood pressure is 80 mm per mercury in systolic and 65 mm per mercury in diastolic, which is hypotension. While percussion and auscultations is normal, the conclusions of cardiovascular system is compromised with positive Quincke signs. The causes of positive Quincke sign in the patient is caused by aortic insufficiency due to the hypoperfusion, where there's a damage in the vascular endothelium causing the fluid leakage towards the interstitial place causing the third place sequestration. While the negative jugular venous pulse is due to the hypotension, while it is caused by the dehydration. While for the sepsis, tachycardia and hypotension indicates that the patient is now experienced septic shock. One more evidence indicates that the patient is now undergo sepsis, which is the heart rate more than 90 beats per minute. For the gastrointestinal tract, during inspection, the oral cavity, the smells is absent. The teeth, they are normal. There's no artificial teeth. The gums, they are pale, they are pale and dry, but there's no bleeding, no ulceration. The tongue, they are pale, they are dry. There's no scar, no deviation, no ulceration. The tonsils, they are not enlarged. They have no scars. Abdomen is enlarged, is asymmetrical. There's right side bulging observed. Breathing by chest. There's no scars, no ascites. There's no visible gastritis peristalsis. There's no caput medosa. There's not the pulsations of the abdomen is present. For the groin area, there's no hernia observed in the groin area. For the auscultation, patient absence of bowel sound. For the abdominal region, there's pain in the right hypochondrium region, right lumbar region, right iliac region, epigastric region, umbilical region, and suprapubic region. The cough signs is positive. Bloomberg sign is positive. Mendel sign is positive. McBurney sign, which is rebound tenderness, is also positive. Presence of fluctuation. Intestinal is not probable because of the enlargements of the abdominal as well as spleen and liver. Percussions of the lower border of stomach. There's presence of down sound because there's a little fluid inside and is located 2 cm above the umbilical line. The liver sign is not able to examine due to the tympanic sound, which indicates that might be an air presence inside the abdominal cavity. There's shifting downwards. Digital rectum examination. The rectum is in normal size and normal form. There's no hemorrhagic stool, no pain, no swelling. The conclusion is gastrointestinal tract system, GIT system. My conclusion is the GIT system is compromised with GIT dysfunction, intestinal paralysis of intestine, and pain in the abdominal region. For the sepsis, there's one more organ is failed, is dysfunction, which is a GIT system, which further proves that the patient is under the conditions of severe sepsis. For the genitourinary system inspection, there's no swelling, no tenderness, no hyperemia, no edema, no scars or lesions, no ulcer, absence of discharge, no inguinal hernia. By palpation, the kidney is not palpable by Obrazov method. The horizontal and vertical position for the palpation, the patient feels pain, there's no displacement of kidney. As well as the percussion, the size of the kidney is enlarged. Pasternatsky size is positive. The upper border of urinary bladder is not detectable. Auscultation, there's bruits heard in the renal artery, while it is a sign of stenosis. And observations of urine, the volume is 25 milliliter from last night 9 p.m. to this morning 9 a.m., which is 12 hours. Color of the urine is brownish color. Clarity is turbid. Blood is absent. Conclusion is the urinary system is compromised with extremely less urine output with abnormal conditions of urine. So we can know, as well as the sepsis, the genitourinary system is compromised, is dysfunction. For the laboratory report, there's increasing of red blood cells, increasing of white blood cells, which indicate leukocytosis, and erythrocyte sedimentation rate is increased. For the biochemistry blood analysis, the carbon dioxide is decreased. The total protein is increased. The albumin globulin ratio is increased. Alkaline phosphatase is increased. AST is increased. C-reactive protein is increased. Lactate level is also increased. For the dipstick urinalysis, the color of the urine is brownish color. The clarity is turbid. The pH is 7.0. The specific gravity is 1.052, which is increased. There's no glucose, no bloods, no ketones, no urobilinogen, no bilirubin, no leukocyte esterase observed, but there's protein in the urine. For the microbiological examination, the microbes observed in the urine is Escherichia coli. For the ECG, the patient is having sinus tachycardia. So the conclusion is the patient is having leukocytosis, increasing of white blood cells, total protein level more than the normal value, which is hyperproteinuria, increasing of erythrocyte sedimentation rate. And in biochemical blood analysis, the patient has imbalance ratio between albumin and globulin, which is dysproteinemia, increasing in AST, ALT, increasing in C-reactive protein, decreasing in carbon dioxide level. In the urine analysis, the color of urine is brownish color, the gravity is high, and it's present protein in the urine, which is proteinuria. This further proves that the patient is in the dehydration state. In the ECG, the patient has regular tachycardia, which is sinus tachycardia with a heart rate of 100 beats per minute. Oximeter is 92%. In instrumental diagnosis, patient is undergoing 3 examinations, which is plain chest X-ray, abdomen X-ray, and abdomen ultrasound. In plain chest X-ray, infected fluid in abdomen is detected, which indicate a rainbow-like shape in the lung region, in the diaphragm region. And in abdomen X-ray, a dilated bowel loops is present, which indicate appendicitis. In abdomen ultrasound, infected fluid is in the abdomen region. So my conclusion is the patient is having peritonitis and also appendicitis. Appendicitis is mostly the cause of peritonitis. Situation is emergency. We decided to take our patient to surgery, which we will remove the appendix. And preoperative checklist is done in 11 a.m. to 11:30. The date is 26th of September. The name is Wong Yong Pyong. Weight, height is written. Vital signs, the temperature is 38.9 degrees Celsius. The pulse is 120 beats per minute. The respiratory rate is 30 breaths per minute. The blood pressure is 65 millimeter per mercury. The patient is not allergic. The patient does not have any communication. The patient does not have any communication problem. The time of last food or liquid consumption is 9 a.m., where the patient is having a porridge for breakfast. Pre-medication given at 11:30. Identifications of brand present and correct is yes. So the checklist is completed for the pre-operative checklist and is signed by ward nurse and tertiary staff. For the treatment of medication, the patient is given complex treatment provided in the ICU department, which is an antibiotic therapy. In intravascular, we are giving a cephalosporin, 3rd generation, ceftriaxone, 25 milligram. Detoxification therapy, Lexis and mannitol. Infusion therapy, Crystalloid is given. For the surgical, appendectomy is done to remove the appendix, and because it is the main cause of the patient's having peritonitis and leading to severe sepsis. And surgical intervention, including the resections of perforated viscus with re-anastomosis of creations of fistula to reduce the bacterial load. lavage of abdominal cavity, with a particular attention paid to the area prone to form sepsis. For the post-operative care, the patient is transferred to ICU for close monitoring. The patient is receiving medication including antibiotic and other supportive treatment. And we are giving patient NPO. Temperature of patient is gradually decreased to normal within 1 week. The skin of condition is turned from dry to moist. At the site of surgical, there's no hemorrhage present, and the wound drains gradually decrease. The urine analysis shows that the patient has normal color, transparency, and the concentrations of urine. There's no blood and stones present. There's no further complications of the sites of surgical. For the blood analysis, everything is remained to normal. At the sites of surgery, antiseptic dressing is changed every day. Locus at the chest of patient shows normal color of skin and normal temperature. So the conclusion is the vital signs are gradually back to normal, which indicate the surgical and medications is working well. The patient can be further transferred to a normal ward and soon will be discharged from hospital. That's all for summary for topic 22, purulent disease of serous cavity, and topic 23, surgical sepsis. Thank you.